Our next section is subarachnoid hemorrhage. This is unquestionably a must-know topic from top to bottom. Subarachnoid hemorrhage is caused by the rupture of an aneurysm. Now, this aneurysm is usually in the circle of Willis. Look at this MRA. Isn't that fantastic? The white is the blood going through the vessels. And aneurysms are found in a lot of people. 2% seems small until you realize that 6 million people in the United States. That is why they're not important unless they've ruptured. And it's hard to take, I understand that. I wouldn't want an aneurysm. But you don't do anything about them unless they're rupturing. Because the majority never rupture. And since the majority never rupture and the cause of the rupture is not clear, we just don't know what to do about an unruptured aneurysm. Here's a diagram to show you the blood supply around the circle Willis and the anterior communicating artery in between the two anterior cerebral arteries. It's also very good for you to help understand why it is that the middle cerebral artery is where the most of the strokes are, and because you can see very easily from this diagram how colossally large a middle cerebral artery is compared to the posterior and the anterior cerebral arteries. One of the most common questions for your exam will be, what is the most likely diagnosis? Well, how I answer that is I'm going to look for the sudden onset of severe headache and meningeal irritation, a stiff neck, and photophobia. You might say, well, isn't that an awful lot like meningitis? And more than you know, because it also gives you fever. So when you see the sudden onset of a severe headache that looks like the sudden onset of meningitis, the difficult part is how are you going to answer the question so you don't say it's meningitis? Because right now, fever, stiff neck, headache, and photophobia looks like meningitis. And the answer to that is loss of consciousness. The only way you're going to be able to answer the question, what's the most likely diagnosis, is they're going to have to describe to you that the person passes out. The person passes out because there's a sudden increase in intracranial pressure. The ability to perfuse your brain is based on the fact that the blood pressure in your heart is greater than the pressure in your head. If the pressure in your head goes up, how can you expect blood to get into there? Therefore, there's a loss of consciousness, and they must describe the time course. Since meningitis can happen over a few hours, but it doesn't happen over seconds. Subarachnoid hemorrhage happens over seconds. In addition, there's focal neurologic complications. Now that by itself, which is to say my arm is numb, my leg is weak, my arm is sensory disturbance, I have ocular problems, by itself that's not enough to distinguish it from meningitis, because one of the things that the average person doesn't know is that meningitis gives neurological abnormalities in 30% as well. 1/3 of people with meningitis have focal neurological findings. But the complication here of focal neurologic findings, not just in the eyes, will help you to recognize it as subarachnoid. The bottom line on how the subarachnoid differs and allows you to answer the most frequently asked question on step 2 comes down to you just have to know 2 lines. It is sudden in onset and there's a loss of consciousness. The best initial test for subarachnoid is, well, what do you see on the right side of your picture? That is a CT scan without contrast. On the first day, you will see it in 19 out of 20 patients. It is 95% sensitive. Now, although the most accurate test is the lumbar puncture, you do not have to do the lumbar puncture in the majority of patients. Now, why don't you do it? It's not because they'll herniate. The most common wrong answer is saying don't do the lumbar puncture because they'll herniate. You don't herniate with an LP and a subarachnoid because you can see that the blood is evenly spread through both sides of the brain. It's evenly spread, left and right, up and down. So you can't herniate if you got something pushing left and pushing right. If you got something pushing from above and below, you can't herniate from that. You herniate from things where there's a blood pressure difference, where there's an intracranial pressure difference. You herniate when there's a pressure difference on one side than the other. You do the lumbar puncture only in the person who has a negative initial CT CT scan. Now, contrast on CT or MRI improves detections of mass lesions such as cancer abscess. You don't use contrast when looking for blood because blood looks like contrast. You lose contrast when you're looking for cancers and infections. Use contrast when you're looking for cancer and infection. A patient comes to the emergency department with fever, headache, stiff neck, and photophobia. Happens very rapidly in onset, and the patient loses consciousness. The head CT shows nothing. What is the next best step in the management of this patient? The answer is lumbar puncture. The lumbar puncture is necessary only for the 5% with a falsely negative CT scan. You see, the CSF and subarachnoid hemorrhage has a lot of white cells, but it also has a lot of red cells. And that's why when you see these white cells, it can fool you easily into making think it's meningitis. Well, how are you going to know it's not meningitis? And that is because in meningitis, the number of white cells is far out of proportion increased compared to the usual ratio. It means that in order to answer the question, what is the most likely diagnosis, which is the most common question on step 2, you will have to know what the ratio is of white cells to red cells. And that ratio between them is normally that you should only have 1 white cell for every 500 to 1,000 red cells. 1 to 500. That means if somebody says, oh, my lumbar puncture showed 100,000 red cells, and somebody goes, yeah, but it must be meningitis because there's like 150 white cells. You go, no, 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 no. 100,000 red cells can have 100 to 200 white cells. It's not meningitis. It's just a dilute CBC. Just like taking water and dumping it into your bloodstream. Just dilutes it out. If the number of white cells is above that ratio, then you should be thinking about meningitis. The other thing that will help you is xanthochromia. That's basically a yellow cerebrospinal fluid. Xanthochromia is the red cell breakdown product. It happens when blood is in CSF for a few hours. Now, if you have a subarachnoid hemorrhage a half an hour ago, and I do a CT and the CT is negative, and I do the LP and I find tons of red cells, you won't have xanthochromia in many people in the first half hour, a couple hours. But xanthochromia is something there that happens over several hours that can help you detect the subarachnoid, particularly one that's a few hours old. The EKG, this is very unique. The EKG will show something with a subarachnoid hemorrhage. The EKG will show from inside your brain you get inverted T waves? Yes, cerebral T waves. Looks like myocardial ischemia, these T waves. Cerebral T waves are from excessive sympathetic activity, or so we think anyway. The moral of the story is they can say to you, a man comes in with fever, headache, stiff neck, photophobia. His CT shows the subarachnoid hemorrhage, and EKG shows T wave inverted. What is the next best step in the management of this patient? Well, the answer is treat the subarachnoid. Now, this is a very big deal. Why don't you think back about all the drugs we use for myocardial infarctions? Don't an awful lot of them involve aspirin, clopidogrel, prasugrel, ticagrelor, low molecular weight heparin? Wow, a lot of them involve anticoagulation, so you better be sure that that's really a cardiac etiology. Subarachnoid hemorrhage causes EKG abnormality. What I'm about to say may seem paradoxical. When is angiography the answer? Angiography is the answer to what is the single most accurate test for the site of a subarachnoid hemorrhage? What is the single most accurate test for an aneurysm that's ruptured? Well, it's the angiogram. However, the angiogram is done not to tell me whether or not you had a subarachnoid. That angiogram is done to determine the site of the aneurysm, because we only need to know the site of the aneurysm. We're going to do something about it. It guides surgical lesion repair, guides intracatheter lesion repair. It guides coiling and embolization. Well, if I'm not going to do coiling or embolization, if I'm not going to do an occasional surgical repair, there's no reason to do angiography. Angiography determines the site of the aneurysm to guide lesion repair. Now, you can do an MRA in the vast majority, magnetic resonance angiography, and you can do that also to guide the location so you can repair it. Now, the diagnosis of that subarachnoid is based on predominantly the CT and 5% of the time, sometimes an LP. And the angiography is only to tell location, and the reason is you want to make sure they don't rebleed. So let's do an angiogram, find out the location, repair it with a catheter, and you won't rebleed. This angiogram is just so you have an idea of what it actually looks like. And this is clearly labeled for the internal carotid, the middle cerebral, and the anterior cerebral artery, just so you have a sense of the outpocketings we might see. It is not that you're going to be asked to read angiograms on your Step 2 exam, but let's know exactly what we're talking about when we're talking about it. The most important thing to understand first about a subarachnoid bleed is that you can't do anything to reverse the bleed that already happened. It's already happened. You can't go stuff it back in there. The major thing that we're going to do is we're trying to prevent complications. The complications is that people who have subarachnoids have vasospasm and get an ischemic stroke. So we use a calcium channel blocker, nimodipine, to prevent a subsequent ischemic stroke. That is because when the blood vessel ruptures, blood vessels, particularly arteries, have muscles in them. Those muscles constrict to contain bleeding. And what happens is that if it constricts too much, it precipitates a stroke. So nimodipine is associated with decreased neurological complications after the subarachnoid hemorrhage. It does not reverse the subarachnoid, it prevents complications. In addition to using nimodipine, we've done the angiogram so that we can clog up the hole. 50% of people who rebleed will die. We do not want you to rebleed. When you wake up after that subarachnoid, the first thing out of your mouth should be, where is the angiogram suite? I want embolization. I want coiling. I want a catheter to clog up that side of bleeding. It will prevent me from rebleeding. It will prevent me from dying. I want my interventional neuroradiologist to place a platinum wire, and I don't want somebody chopping through the side of my head with a knife, because embolization is superior to surgical clipping for both survival and complications. Also, I think a 20-minute catheter procedure is far superior to somebody hacking through the side of my skull and lifting up my brain. We use platinum for a very simple reason. Platinum does not wear out. Platinum does not corrode. It doesn't oxidize. It doesn't have any version of what could be called quote-unquote rust. It stays up there in your head forever, pure and clear and beautiful. The third potential treatment is ventricular peritoneal shunt. Subarachnoid hemorrhage associated with hydrocephalus. That's because the red cells get clogged up in the subarachnoid granulations. The subarachnoid granulations are what drain out the cerebrospinal fluid from the brain. Red cells literally clog it up like you would have toilet paper stuffing up your toilet. And you shunt it only if the hydrocephalus develops. Remember, 50% of those who rebleed will die, so the most important thing is to get in there and clog up the side of bleeding so it doesn't happen again. What will your answer be regarding seizure prophylaxis? A person has had a subarachnoid hemorrhage. Phenytoin yes, phenytoin no. And the answer is very clear. Clearly, no. Phenytoin is not routine, nor is any other medication to prevent seizures just for having a subarachnoid hemorrhage. If the question asks, which of the following is most likely to decrease mortality? Phenytoin is not the answer. In addition, as with cardiology, consultation is only right when you want to do a procedure that isn't given one of the choices. You should not need a consultant to tell you to use nimodipine. Now, although you certainly are not a person to be doing the coiling and the embolization, you should answer the name of the procedure if you can, rather than saying the word consultation. A woman is in the emergency department with a severe headache of 1 day's duration prior to admission. That's pretty sudden. She's got a big fever, 103, stiff neck, photophobia, and her head CT is normal. The lumbar puncture shows 1,250 white cells and 50,000 reds. What is the next step in the management of this patient? Looking at these answers is ceftriaxone and vancomycin. And that's because this is far more white cells than you should have for this number of reds. This question is indispensable because at a ratio of 1 white cell for every 500 to 1,000 reds, this person should only have 50 to 100 white cells. This is 50,000 red cells. They should have 50 to 100 white cells. So therefore, this is 10 times more white cells than should be there. This is meningitis, ceftriaxone and vancomycin. And that is why when you see 50,000 reds, you shouldn't be over 100 white cells. Angiography is for the location of a subarachnoid. This simply is not a subarachnoid. Nimodipine prevents a subarachnoid stroke. This is not a subarachnoid. Embolization is a permanent fix of the subarachnoid. It prevents rebleeding, and it is done if you have a subarachnoid and is superior to the surgical clipping, because that's a worse alternative to embolization. There's no point in repeating the CT scan with contrast, because this is not what you do, one, when you're looking for blood. Contrast looks for cancers and infections. Number two, you're not going to find any mass lesions when you just did a head CT, and it is meningitis. We don't need consultation because there's no procedure that we're looking for. We don't have a procedure we're looking for, don't need them.